We're going to start a series of lectures on glomerulonephritis. So the basic purpose in the first one or two lecture is to understand the basic concepts which are important to understand the clinical manifestations of various glomerulonephritis. So the first two lectures are crucial before we jump onto the individual glomerulonephritis. So I'll give you the main concepts so that we understand why and how the glomerulonephritis they present clinically. First of all, let's see what the glomerulus is. Glomerulus is basically, I'll show you a picture. Glomerulus is basically a bunch of capillaries. If you look at this picture, so this is a glomerulus. You can see there's a bunch of capillaries which is surrounded by the green layer called as Bowman's epithelium. So efferent arteriole enters into the glomerulus. It splits into many capillaries, and then those capillaries they are part of the glomerulus. Then they unite and make efferent arteriole. Remember, E for efferent, E for exit. So the one which is exiting is start with E, and one which is entering the glomerulus start with A, right? And each capillary in the glomerulus is surrounded by the Bowman's epithelium in its 2/3 circumference. The remaining uncovered 1/3 circumference of the glomerular capillary is covered by these blue areas, which is blue connective tissue-like material called as mesengium. Okay, so mesengium basically is in contact with the glomerular capillaries, but primarily only in the areas which is not covered by the Bowman's epithelium. So each capillary has 2/3 circumference covered by the Bowman cells, and 1/3, almost 1/3 circumference is covered by the mesengium. And the main purpose of the glomerulus, because glomerulus is a filter, the main purpose of this filter is to filter the blood. Remember, the blood has blood cells, proteins, and plasma, except the proteins. The plasma component, excluding protein, has water, electrolytes, and waste products. Okay, so everything in the blood gets filtered except blood cells and except plasma proteins. These are the two things which are not filtered by the glomerulus into the urine. Rest everything, including water, electrolytes, and waste products, they are filtered by the glomerular capillaries freely into the Bowman space. And the Bowman space continues as proximal tubule onward. Okay. So the main purpose of the glomerulus is to act as a barrier, to act as a filter. When we place a barrier, we mean that few things can pass and few things will be held back. The things which will be held back in the blood are blood cells and plasma proteins, and the things which are filtered easily from the glomerular capillaries into the Bowman space they are water, electrolytes, waste products, and nutritional chemicals such as amino acids and glucose. And the Bowman space then continues as the proximal tubule. So the barrier between the blood in the capillaries and the Bowman space consists of three layers, and that is called as a glomerular filtrate barrier, okay, or glomerular filter. So it consists of three layers. If you look at this picture, this is basically I've taken a cross section of the capillaries here, okay, and the Bowman cells, and made it in a bigger one. It consists of three layers. The red cells, the red layer, the topmost, which is in contact with the blood, is capillary endothelium. You can see the tiny openings in those capillary endothelial cells, right? And these are called as fenestrations. So that means capillary endothelium itself is not a complete barrier. Then the second layer, the blue one, which is crisscross, is made up of collagen, is called as glomerular basement membrane. And that also has some tiny spaces between the collagen fibers. So that means that basement membrane also is not a complete barrier. Then the third layer, the outer layer, the green layer, which is toward the urine side, is the foot processes or the podocytes. These are the foot processes of Bowman's epithelial cells, which are attached to the basement membrane. They also have gaps in between, so they are also not a complete barrier. Now, if you look at these three layers, none of them in itself is a complete barrier, but when they are functionally and structurally intact, they make a complete barrier. Okay, so when they complement each other, and they are the one which prevent the blood cells and the proteins to leak into the urine. Okay, so as long as all three layers of the glomerular barrier, including capillary endothelium, basal membrane, and podocytes, they are intact and they're functional, blood proteins and the blood cells, they don't leak into the urine. If we damage this barrier or this filter, then the blood cells and the protein will start leaking into the urine, right? So this is the glomerulus, afferent arterioles, mesenterium, Bowman's space, capillaries, and Bowman's epithelial cells. And this is the fine detail of the glomerular barrier. Now, how does plasma proteins and the blood cells can leak into the urine? Okay. Remember, out of these three layers, if we damage one of the three layers, for example, we damage the endothelium or we damage the basal membrane, we'll talk in detail how they get damaged, or we damage the podocytes. If we damage one of the three layers, the protein will start leaking. So for the proteinuria, we only need damage to one of the three layers of the glomerular barrier, either endothelium or glomerular basal membrane or podocytes. Blood cells are much bigger than the proteins. Blood cells will only leak if there's a physical rupture of all three layers. So for the hematuria, for the red blood cells to come into the urine, to come into the Bowman space, all three layers, endothelium, basal membrane, and podocytes layer, Bowman cells should be damaged. There should be physical rupture of the glomerular capillaries, including the Bowman layer. Only then the hematuria will happen. Whereas proteinuria can happen only if one of the three layers is damaged, or two layers are damaged, or three layers. So for proteinuria, we need at least one of the three layers to be damaged. For hematuria, we need three layers, all three layers to be structurally damaged, which physically mean a rupture of the glomerular capillaries. Let's see how that can happen. For the one of the three layers to be damaged, remember the endothelium is in contact with the, going back to this picture, the endothelium is in contact with the blood. So the capillary endothelium can be damaged by chronic hypertension. Remember at the beginning of the capillary, here, at the beginning of the capillary, from the arterioles to the capillary, there is usually a pre-capillary sphincter. And the purpose of the pre-capillary sphincter is to control the blood pressure, to lower down the blood pressure, so that when the blood enters into the capillaries, the pressure of the blood is less than 30 millimeter of mercury. Patients with severe hypertension or with the chronic hypertension, they can ultimately have damage to the pre-capillary sphincter, and they can also cause damage to the capillary endothelium. So they can have proteinuria. Now let's see how the basal membrane can be damaged individually. Remember, basal membrane is made up of collagen. Okay, and these collagens are finally interlinked with each other in a. If you look at this here, these are the collagen which is crisscrossed, finely woven, making a very uniform thickness of a basal membrane. These collagens are held together by collagen-collagen bond. Remember, bond is a union of two molecules or two atoms based on the fact that one of them needs electron and the other one has extra electron. Okay. So collagen and collagen, they also make a bond just based on the same principle. If a foreign chemical comes and deposits in the basal membrane, then it will make a new bond with the collagen at the cost of the pre-existing collagen-collagen bond. So whenever there's a chemical deposition in the basal membrane, that will break the collagen-collagen bond, and that will make a new bond with the chemical being deposited. For example, patient who has diabetes, the glucose will deposit in the basal membrane, and it will make collagen-glucose bond, and it will break the collagen-collagen bond, and collagen will disperse. And this is what will happen. When the collagen will disperse, now remember, look at this in the original picture, the basal membrane is very uniformly laid, uniform thickness, and the collagens are finely interlinked with each other with very tiny spaces. Compare this when the collagen-collagen bonds are broken due to deposition of the extra chemical. Now look at this one. this is what is happening when there's a basal membrane becomes leaky. Collagen has dispersed because of the deposition. These black chemicals are representing external chemical depositing in the basal membrane. So for example, it could be glucose, it could be an antigen, it could be a protein, it could be a drug, it could be infectious antigen or cancer antigen or any other antigen. I'll come back in the detail. Or it could be a myeloid protein. So any chemical deposition in the basal membrane will cause leakiness of the basal membrane. Look how the collagen has dispersed because of the breakdown of the collagen bond, and the space between the collagen and collagen fibers has increased. So this makes the basal membrane very leaky. And also note now how widened the basal membrane has become. Initially, the basal membrane is very uniform but not very wide. Okay, when we disperse the collagen bond, like here, that make the basal membrane leaky because of the dispersion of the collagen and increase space between the collagen fibers, but that also increase the thickness of the basal membrane from here to the here. This will compromise the capillary lumen. Okay, and because this, if you expand this basal membrane, this will push on the capillary lumen, and the capillary will get occluded, and that will cause reduced blood flow and reduced GFR. So any chemical deposition within the basal membrane will cause proteinuria. Okay. Similarly, the third layer is podocytes, food processes. If the endothelium is intact, basal membrane is intact, but we lose the podocytes. Okay. Because one of the three layers is not physically intact now, patient will start having proteinuria but no hematuria. Okay, that is what happens in minimal chain disease. So, coming back to the point that for the proteinuria, we need damage to one of the three layers, either endothelium or basal membrane or the podocytes. Endothelium can be damaged in chronic hypertension, chronic poorly controlled hypertension. Basal membrane can be damaged individually by the deposition of any chemical in the basal membrane, such as glucose, amyloid proteins, cancer antigens, drug antigens, infectious antigens, idiopathic antigens or autoimmune antigens. And podocytes are damaged by the immune process in minimal chain disease. Okay, so that causes proteinuria. Now, how does hematuria happen? We'll come back to the proteinuria in detail. For hematuria, we need the physical rupture of all three layers. All three layers should be physically ruptured: endothelium, basal membrane, and Bowman cells. Okay, that physical rupture of the Bowman's space and the basal membrane and collagen can happen due to one of the three reasons. Either there is a inflammation in the glomerulus that will cause damage to the capillaries and rupture the capillaries because of inflammatory damage. Second mechanism is very high pressure. Remember, we said that at the beginning of of the capillaries, here, when the arterioles they transform into the capillaries, there will be a pre-capillary sphincter here at this point. And the purpose of the pre-capillary sphincter is to lower the systolic pressure so that when the blood enters into the capillaries, the pressure is less than 30 millimeter of water. If the blood pressure goes very high, such as happen in malignant hypertension or hypertensive emergencies, in that very high pressure can damage the pre-capillary sphincter, and now there's no barrier between the arterioles and the capillaries, and the capillary will have to face the very high pressure and the capillaries will rupture. So one of the mechanisms of glomerular capillary rupture is malignant hypertension. So the second mechanism is inflammation in the glomerulus. And the third mechanism of rupturing the of the capillary is a genetic disease called as Alport syndrome, which has a thick and thin basal membrane. Some areas of the basal membrane are thick and some area of the basal membrane are thin. So where the basal membrane is thin, the podocytes and the endothelium is not well supported, and all three layers they sag down and they rupture. Okay, so that is a genetic disease. So we can rupture these capillaries in the glomerulus by one of three mechanisms: either malignant hypertension, or inflammation in the glomerulus, or the third one is Alport syndrome. If the Alport syndrome, because it's a genetic disease, so that would present in pediatric age group most of the time, and that also affects the inner ear because that affects two areas. One is the glomerulus, and the other is the hearing cells in the inner ear. So patient has a neural deafness due to inner ear damage to the hearing cells, and the patient has uh, rupture of the glomerular capillary presenting as a nephritic pattern. Okay, it's not inflammation, but it presents like hematuria-like syndrome or nephritic syndrome. Okay, now, and malignant hypertension, of course, there will be very clear the patient has a hypertension, very high blood pressure, which can affect many organs, including the glomerulus, and patient can have glomerular hematuria. Now, when the third mechanism is inflammation. We'll come back to the inflammation in a second. When the blood cells they leak from the glomerulus and they falls into the Bowman space, they have to pass through through the renal tubules to go into the urine. Remember, the lumen of the renal tubules is smaller than the size of the red blood cell. So red blood cells have to squeeze. They become crenated, dysmorphic. Look at the shape of these red blood cells. These green are the tubules, renal tubules, and these red are the red blood cells. So they have to pass individually. They have to make a queue like this: 1, 2, 3, 4. They have to make a queue. They have to squeeze, so they become dysmorphic, crenated red blood cells in a queue form. When they're passing through the tubule, they get they have to make a queue, and they get stuck to each other. There's a protein in the tubular lumen called as TAM horsefall protein, TAMM HORSFALL, horsefall protein. Okay, they act as a glue, and that red blood cells they become sticky to each other. These dysmorphic red blood cells, which are in a queue in a linear fashion, and they are stuck to each other, this is called as red blood cell cause. Okay, so red blood cell cause is a good marker that this hematuria is coming from the glomerulus. Remember, they have to make a cause because the size of the tubular lumen is smaller than the size of the red blood cells. Okay, if there's a hematuria from the bladder is quite big in size. Urethral size is much bigger than the size of the red blood cell. So the red blood cell don't have to squeeze, they don't have to make a queue, and they don't have to get stuck to each other in a linear fashion. So cause formation is not there if the hematuria is coming from the lower urinary tract. Cause for red blood cell cause means that blood cells have passed through the renal tubules. And that is possible if there's a glomerular disease causing glomerular capillary rupture, causing hematuria. Okay. So the clues for glomerular hematuria, number one is a red blood cell cause. Number two is a dysmorphic crenated red blood cell. Number three, remember the glomerulus is made up of capillaries, as I said. Okay. And how much blood a capillary has? Capillary will have just less than a ml of blood. So if you rupture a few capillaries or some of the capillaries, the very small quantity of the bleeding will occur, and it is usually microscopic. So remember, glomerular hematuria is microscopic, is never macroscopic. It's not grossly visible. If the hematuria is grossly visible, it's more likely macroscopic and is more likely from the lower urinary tract system rather than from the glomerulus. So glomerular hematuria is microscopic because it's a capillary bleed. Second, glomerular hematuria has dysmorphic red blood cells because the red blood cells has to squeeze when they're passing through the tubule, and the glomerular hematuria usually has a red cell cause formation. But remember, for the detection of the red cell cause, it's very important that we send as fresh sample as possible, because if the urine stays in the bladder for longer, or in the sample container for longer time, these red blood cells will break. They will hemolyze, and they will not be in the cause form, and they may not be even detectable. So for the detection of glomerular hematuria, especially the red cell cause, we should send as fresh sample of the urine as possible. Okay. So to summarize, the glomerular hematuria clues are microscopic hematuria, dysmorphic or crenated red blood cells, and red cell cause. and it may be associated with proteinuria as well. So that is how the glomerular hematuria can happen, right? Now, this is the concept how what the glomerulus is and how does proteinuria happen and how does hematuria happen. For proteinuria, all we need is damage to one of the three layers, okay? Either endothelium or basal membrane or podocytes, food processing. For hematuria, we need a physical rupture of the membrane of the glomerular capillary. And physical rupture happens either with the malignant hypertension or with the inflammation or with Alport syndrome. Now, let's see the concept how the inflammation comes into the glomerulus, okay, which is called as glomerulonephritis. Okay. Remember, not all the glomerulonephritis are inflammation. Some of them are inflammation and some are not. We'll discuss them one by one when we go through. But those which are inflammation, they will present as glomerular hematuria. They will cause physical rupture of the capillary. If you look at the renal blood flow, 90% of the renal blood flow 90% of the renal blood flow goes to the glomerulus. So glomerulus is a highly vascular organ. So, and most that means is high that has a good, maximum immune system as well. So it's very, very rare to have an infection in the glomerulus. It's very rare. You will never hear that there is a bacterial glomerulonephritis or a viral glomerulonephritis or a fungal glomerulonephritis or tuberculosis of the glomeruli. Is unheard. Okay, so infection is extremely uncommon in the glomerulus. So inflammation in the glomeruli is not infectious. Okay, because 90% of the blood goes to the glomerulus and the immune system is the maximum in the glomerulus. Okay, so most of the time the inflammation in the glomerulus is immune mediated. It's immune system problem which causes inflammation in the glomerulus. Chemicals in the glomerulus, the blood flow in the glomerulus brings the many chemicals in the glomerulus, but they don't stay longer in the glomerulus. Look at here. The blood is coming through the arterioles, efferent arteriole in the capillaries, and it takes a less than a fraction of a second for the chemical to be filtered into the Bowman space, and then it will flow down into the tubules. So that means the chemicals are not going to stay in the glomerulus. So inflammation in the glomeruli is not chemical mediated, is not infection, is immune mediated. And the second is because the 90% of the blood flow goes to the glomerulus and only 10% goes to the tubule. If there's a high blood pressure, that will affect the glomerulus much more than the tubules. So glomerular problems are mainly either because of autoimmune diseases, immune problem, or because of the chemical deposition within the basal membrane, such as glucose, or because of the high blood pressure. Whereas the tubules have only 10% of the blood supply. So because they only get a 10% of the blood supply, so infection is very common in the tubule. So pyelonephritis or infections of the kidneys, they mainly affect the tubules and the interstitium. Okay. Secondly, because the tubules are only get 10% of the blood supply, they are very much ischemia prone. So ischemia is more common with the tubules rather than with the glomeruli. Okay. And thirdly, the tubules are the one which are in contact with the ureteric system. So the back pressure in the ureteric system, hydronephrosis, will affect the tubules much more than the glomeruli. So tubular diseases are mainly infection, ischemia, back pressure, which is hydronephrosis, or the toxins. Because when the toxins are filtered from the glomerulus into the tubules are the one which they try to reabsorb almost everything which is filtered by the glomerulus. And when they reabsorb those toxins, that can damage those tubular cells. So tubular diseases are mainly infections, ischemia, toxins, and hydronephrosis, back pressure. Glomerular diseases are mainly immune mediated, chemical deposition in the glomerular basal membrane, and blood pressure related problems. Okay. Now, how does the inflammation comes in the glomerulus? We started that is autoimmune, is immune mediated. Now, who invites the immune system in the glomerulus? There are four main mechanisms how the immune system can be brought into the glomerulus. One is antigen deposition in the glomerulus. Any antigen, if it get deposited in the glomerulus, such as cancer antigen, such as infectious antigen, you must have heard the post-streptococcal glomerulonephritis, in which the bacterial antigen they deposit in the glomerulus. Similarly, the cancer antigens can deposit in the glomerulus. Drug can act as antigen, as haptens or antigens. Autoimmune antigens can deposit in the glomerulus, and sometimes the antigen is not known. So antigen deposits in the glomerulus, then it brings the antibodies there, make immune complex in situ in the glomerulus, and then the complement system is activated, and complement bring the inflammation. This is one of the mechanisms. Second is immune complex deposition. That antigen and antibody, they are circulating in the blood, and they make immune complex. Combination of antigen and antibody, which is freely circulating, is called as immune complex. And then they deposit in the glomerulus. So that is immune complex. And when the immune complex is deposited, that will bring the complement system, and that will activate the inflammation. So these two mechanisms, they are complement dependent. Either antigen alone or immune complexes, they activate the complement system, and then they bring the inflammation. The third mechanism is that it's not antigen, it's just the antibodies. Okay, there's no antigen involved. Antigen is part of the glomerulus or is unknown, but antibodies are the main one which attack the glomerulus without any known antigen, and that because it's not antigen and antibody combination, so it doesn't activate the immune complement system. It just causes direct inflammation through the antibodies. Okay, so in this case, for example, ANCA antibodies or anti-GBM antibodies, they damage the glomerulus. They cause inflammation in the glomerulus without activating the complement system. So in these antibody-mediated activation of inflammation in the glomerulus, the complement is not involved. So serum level of the complement is normal in these cases, and renal biopsy will show no complement deposition in the glomerulus. So ANCA ANCA vasculitis or anti-GBM good passage syndrome, when they cause glomerulonephritis, they do not involve complement system because they are primarily antibody mediated damages. They are not antigen antibody combination. They are not immune complexes. Okay, so they are also called as post-immune glomerulonephritis, that there's no complement system involvement in the inflammation. Okay, and the fourth mechanism is just complement on its own is attacking the glomerulus. One of the example is a C3 glomerulonephritis. Okay, so these are the four mechanisms how the inflammation can come into the glomerulus. I'll repeat it. Any antigen such as cancer antigen, infectious antigen, drug antigen, autoimmune antigen or idiopathic antigen, they can come and deposit in the glomerulus, and then the antibodies against those antigens can attack there, and then complement system is involved and inflammation comes through the complement. Second is immune complexes made in the blood, circulating in the blood. They deposit in the glomerulus, and they cause complement activation, and complement bring the inflammation there. Third is direct antibody-mediated damage, which is oncovasculitis or Goodpasture syndrome. They do not involve the complement system in the blood or in the glomerulus. So there's no complement deficiency in the blood, and there's no complement deposition in the glomerulus. Okay, these are diagnostic points which will help us, and this is called as post-immune glomerulonephritis as well. And the fourth one is a complement-mediated. No antigen is there, no antibody is there. It's direct C3 or complement system which is getting activated without any stimulus, and that attack the glomerulus. Example is a C3 glomerulonephritis. Okay, so these are how the inflammation comes in the glomerulus. Okay, right. Now, remember, when we said that the proteinuria happens when there's damage to one of those three layers, so damage to the single layer, such as damage to the basal membrane, was because of the non-inflammatory inflammatory damage to the basal membrane, and that was not inflammation, that was just a chemical deposition within the basal membrane. That chemicals makes bond with the collagen and breaks the pre-existing collagen bond and causes leakiness. There's no inflammation involved. Okay. Similarly, malignant chronic hypertension affecting the endothelium, there's no inflammation involved. Similarly, women's just antibodies damaging the food processes, there's no inflammation involved. Okay. So they are non-inflammatory glomerular pathologies. Okay. Now, what are the consequences of the inflammation in the glomerulus? When inflammation comes in the glomerulus, what it does, what potentially it can do in the glomerulus? We know the immune system brought the inflammation by one of the four mechanisms: antigen alone, bringing the antibodies, complement immune complex, direct antibody, or C3, complement, direct complement. Okay. Now, let's see what happens when the inflammation comes. Remember that when the inflammation comes in the glomerulus, it's mainly the lymphocytic inflammation. Okay. Mononuclear cells inflammation is not neutrophilic inflammation. Neutrophilic inflammation is extremely rare because neutrophils come when there's a bacteria or any other infectious agent there sitting there. Okay. Now, when the inflammation comes in the glomerulus, there will be following consequences. Number one, wherever there's inflammation, it causes damage and repair. So, of course, the inflammation will cause damage to the capillaries, rupture of the capillaries, and that will cause hematuria, glomerular hematuria and proteinuria, and that's called as nephritic syndrome with Nephritic, nephritic syndrome. Okay. Now, that is one consequence. Of course, when there's inflammation, there's an inflammatory fluid, there is inflammatory cells, and that inflammation will need some space. So if we are bringing inflammation in this space, that of course will be inflammation in the mesangium or inflammation in the capillary wall, and that expansion of the mesangium or edema in the mesangium or inflammatory fluid and inflammatory cells in the mesangium and in the capillary wall or in the they will compromise the capillary lumen. So the second consequence of inflammation in the glomerulus is compromised capillary lumen. So some of the capillaries will be rupturing because of the inflammatory damage, and some of the capillaries will collapse because of the compression from outside caused by the inflammatory fluid and inflammatory cells. Okay. The third consequence which will happen, first was rupture of the capillaries causing nephritic syndrome, hematuria, glomerular hematuria, and proteinuria. Second was compression of the capillaries causing reduced blood flow and fall in GFR and decrease in renal functions. The third consequence, remember, inflammation is mononuclear inflammation, lymphocytes and monocytes. Whenever there's inflammation involved by the lymphocytes and monocytes, they produce a lot of the growth factors. So the third consequence of inflammation is a growth proliferation of within the mesangium. So what is there in the mesangium? There are three. What is there in the glomerulus are the mesangial cells, and then there's endothelial cells, and then there are Bowman cells. So when these inflammation will produce growth factors, when the inflammation will produce growth factor, that will cause proliferation of these native cells in the glomerulus, and that proliferation of the mesangial cells is much more common than the proliferation of the capillary endothelium, and the least proliferating cells are the Bowman cells. Okay, nature is very kind. Just look, if we cause proliferation of the Bowman cells, okay, the Bowman cells will proliferate and they will replace the whole glomerulus like this. That is called as a crescent formation. So nature is very kind. That made the Bowman cells very resistant to proliferate. So Bowman cells are the least common to proliferate. They will only proliferate when the inflammation is very severe and the growth factors are very strong in the glomerulus. Otherwise, capillary endothelium and the mesangial cells, they will proliferate. So whenever the term proliferation is used in terms of medicine, unless it is specified, it means the proliferation of the mesangial cells and the endothelial cells. Okay, so this is an important concept. So proliferative glomerulonephritis is equivalent to inflammatory glomerulonephritis, because proliferative, the term proliferative, it is driven because of the because of the proliferation of the mesenchyme and endothelial cells and the Bowman cells. Okay, and the proliferation only happens when there's inflammation, because it needs growth factors. Okay, and growth factors are produced by the inflammatory cells. So the proliferation in the glomerulus, or the proliferative glomerulonephritis, which is equivalent to the inflammatory glomerulonephritis, the most common proliferation is the mesangial proliferation. So unless it is specified, if it's just labeled as proliferative glomerulonephritis, that will mean mesangial proliferation and capillary endothelial proliferation. Okay, it's also called as a mesangiocapillary proliferation, which means mesangial cell proliferation and capillary endothelial cell proliferation. Okay, now that proliferation, of course, when the mesangial cells are proliferating, they will expand the mesangium. So that will cause mesangial expansion, and that will compromise the capillaries. Okay. The capillary will be compromised, capillary will be compressed, and that will cause fall in GFR and fall in the renal function. Similarly, when the endothelial cells will expand, they will fill up the capillaries. The capillaries will be filled up like this, and that will block the capillary lumen. Similarly, like this, okay, that will block the capillary lumen. So that's when it happens, that will further compromise the renal function. So proliferation of the mesangial cells and proliferation of the capillary endothelial cells will include the capillary lumen. Okay, so this is so the third consequence of inflammation in the glomerulus is the proliferation of mesangium and proliferation of capillary endothelium, right? And the fourth consequence, I'll come to the proliferation of the Bowman cells in a second. Okay? But fourth consequence of proliferation of the inflammation in the glomerulus, ultimately this inflammation, if it's not controlled, all these chronic inflammatory cells, they keep producing the growth factor, and ultimately the mesangial cells, they transform into something like fibroblasts, and they cause fibrosis of the glomerulus. Because it's not primarily driven by the fibroblast, so it's not termed as fibrosis, but it's called as sclerosis. So the fourth consequence of uncontrolled long-term inflammation in the glomerulus is a glomerulosclerosis, which will include all the uh, components of the glomerulus. So glomeruli will be obliterated depending upon the extent of the fibrosis. Now, coming back to the proliferation, the third consequence of the inflammation, proliferation of the Bowman space. When the proliferation of the Bowman space happens, okay, that only happens when the inflammation is very severe. When the inflammation is mild to moderate, it causes proliferation of the mesangial cells and the capillary endothelial cell. But when the inflammation is severe, that causes extensive leakage of the fibrinogen. Remember, plasma proteins, when they are in the blood, they are very useful. When they come out of the blood into the body tissues, they start acting as a growth factor. So all the plasma protein, when they leak from the plasma, they act as a growth factor. Okay. Now, the bigger is the size of the protein, the stronger will be the growth factor. Okay? So fibrinogen is the biggest protein, and that is the strongest growth factor. Albumin is the smallest protein, and that is a weaker protein, weaker than the fibrinogen. Okay, so for the Bowman cells to proliferate, we need fibrinogen, and that fibrinogen usually not only fibrinogen but also in a greater quantity. That is only possible when the inflammation is extensive, and that causes extensive damage to the many capillaries and causes leak of significant amount of fibrinogen. That will cause proliferation of the Bowman cells, and that will make crescent formation. The filling up of the Bowman's capsule, filling up of the Bowman capsule with Bowman space with the Bowman cells. You can see this green one. Okay, it looks like a crescent. Okay, it's called as crescenteric glomerulonephritis or rapidly progressive glomerulonephritis. Now you can see that it has completely occluded the lumen of the glomerulus. Now this glomerulus is completely gone. Okay, unless we clear this crescent. So crescenteric glomerulonephritis causes renal failure. Okay? If majority of the glomeruli are involved, it will end up in renal failure and dialysis dependency. That's why it's called as RPGN, because the patient will end up in dialysis in 2 to 4, 6 weeks after the onset of the symptoms. Okay, so this crescent formation initially is cellular because it is made up of the Bowman cells and the inflammatory cells. Ultimately, those cells will lead to fibrosis, and that will become sclerotic or fibrotic crescents. So it if the crescent is basically cellular, it means the inflammation is active and immunosuppression will work. But if the crescents have changed into fibrosis, that means now it's an irreversible process, and immunosuppression is not going to work. Okay? So proliferation of the Bowman cells is uncommon, but it can happen only when the inflammation is extremely severe. So basically, crescentic glomerulonephritis or RPGN is a consequence of any severe inflammatory glomerulonephritis. Okay, RPGN or crescentic glomerulonephritis or crescent formation is not a primary diagnosis; it's almost always secondary to a severe glomerulonephritis. And the most common cause of crescent formation is oncovasculitis. Second is anti-GBM or a good patcher syndrome. Rest all the inflammatory glomerulonephritis, they are less common to cause crescent formation. Okay, so if you don't know the cause of crescentic glomerulonephritis and there's no immune complex deposition, there's no complement deposition in the glomerulus, this is oncovasculitis or this is a anti-GBM syndrome unless proven otherwise. I'll say it again. The most common cause of crescent formation is oncovasculitis because that causes extensive damage to the glomerulus, that causes extensive rupture of the glomerular capillaries. Similarly, anti-GBM syndrome damages the basal membrane of many glomeruli, and that also causes extensive crescent formations. Okay, so oncovasculitis and Goodpasture syndrome or anti-GBM syndrome, they are the two most common causes of crescent formation. Rest all the inflammatory glomerulonephritis, they can cause crescent formation, but less commonly. Only if they're very severe, such as lupus nephritis, post-streptococcal glomerulonephritis, IgA nephropathy, all other inflammatory glomerulonephritis or proliferative glomerulonephritis, if they are severe, they can cause crescent formation, but they are not very common to go to that level of severity. So most commonly, crescent formation is seen in oncovasculitis or anti-GBM syndrome. Because both of these are antibody mediated without the involvement of the complement system, so they have normal serum complement level, they have no complement deposition in the glomerulus. So if we have a crescent formations in the glomerulus and patient's serum complement level is normal and there's no complement deposition in the glomerulus, even if the onco antibodies or anti-GBM antibodies are negative, which can be a case in almost less than 10% of the cases, antibodies can be negative in the blood. Even if the blood levels of those antibodies is negative, it is still a very diagnostic clue for oncovasculitis or acting as a glomerulonephritis or anti-GBM syndrome. Okay, right. So these crescents, they are indicator of a severe inflammation, severe proliferation, and they cause now they're called as rapidly progressive glomerulonephritis. That rapid is not as rapid. It's not causing renal failure within a day or two, because these Bowman cells are slow to proliferate. So even if they start proliferating, number one, they will only proliferate if the inflammation is extremely severe, where there's a lot of fibrinogen has leaked out. Secondly, even if they start proliferating, they will take longer time to proliferate. So to get to the point that they fill up the crescents and they make crescents and they fill up the whole Bowman's capsule, that will take many days to a few weeks. So even if the RPGN is there, it causes rapidly progressive glomerulonephritis. It causes renal failure within weeks, not in days or not in hours. So RPGN, rapidly, the word rapid should not be misunderstood. And it doesn't mean that the renal failure is happening in a day or few days or few hours. Okay, renal failure will happen in 2 to 6 weeks from the onset of the disease. That is because of the slow proliferating pace of Bowman's epithelial cells. See how nature is very kind. Nature has made these Bowman cells very resistant to proliferate so that it's the chances of going into RPGN they are less. Okay. Now these are the consequences of the inflammation. So just to summarize the consequences of inflammation in the glomerulus, number one is capillary damage causing glomerular hematuria and nephritic syndrome. Number two is capillary occlusion causing reduced blood flow and fall in renal functions, including GFR. Number three, proliferation of the mesangial cells and capillary endothelium, also called as mesangiocapillary proliferation. It can just be a mesangial proliferation, or it can be a combination of mesangial and capillary endothelium, or it can be just a endothelial proliferation. Okay, right? There are few glomerulonephritis which predominantly involve the mesangium only, such as IgA nephropathy. Okay, and there are few glomerulonephritis which primarily involve the capillary endothelium. Okay, and there are few which involve both. Okay, so proliferation of the mesangium alone, or mesangium and capillary endothelium in combination, or capillary endothelium alone, and fourthly, they can cause, because of the proliferation of the Bowman cells, they can cause crescent formation, which in the beginning are cellular crescents, and ultimately they can transform into fibrotic crescents. And the fifth consequence is ultimately, if the inflammation is uncontrolled and extensive, it will cause fibrosis in the glomerulus, and which is called as glomerulosclerosis. Okay. Now, what are the consequences of glomerulosclerosis? Okay. Now, glomerulosclerosis, it it depends upon if it's the whole glomerulus is occluded, or and all the glomeruli are fibrotic, or only a few of them are fibrotic. When it's partial, when some part of the glomerulus is involved, or only a few glomeruli are involved, less than 50% glomeruli are involved in the fibrotic process or by the damage, it's called as focal segmental glomerulosclerosis. Focal means the part of the glomeruli which is the glomeruli which are involved, they're not completely involved. Some part of the each glomerulus is involved, and some of the glomeruli are involved. Less than 50% are involved. Focal segmental. Okay. So that means that more than 50% of glomeruli are still working. They are still normal. Those remaining glomeruli, now they have to compensate the damaged glomeruli, or glomeruli which are fibrotic now. So those glomeruli, they start hyperfiltering. Because of the hyperfiltering, the pressure in those normal glomeruli increases, and they start having damage to their basal membrane and the podocytes and the endothelium, and they start leaking proteins. The consequences of glomerulosclerosis when it's focal segmental is leakage of proteinuria, leakage of proteins through the remaining intact glomeruli. Okay? The one which is already fibrotic is occluded. It's not going to work. It's not going to leak. It's the remaining glomeruli which start leaking proteins because of compensatory hypertrophy, and ultimately start leaking because of increased intraglomerular pressure and volume and stretching of the basal membrane and endothelium. Their openings, they become wide and they start leaking. So partial or focal segmental glomerulosclerosis causes nephrotic syndrome. When almost all the glomeruli are occluded by the fibrotic process, that causes end-stage renal disease or end-stage renal failure, which is not reversible. Immunosuppression is not going to work now, and the patient becomes dialysis dependent. Okay? I think I'll stop here, and we will continue the remaining in the next lecture. Thank you.